Okay, in this video we're hopefully going to be wrapping up the heart. We're starting towards the back after EKGs. So the next thing in the notes is cardiac output. Cardiac output, you can see the definition that is up there. I do want you to know that there is a formula for calculating cardiac output. It equals heart rate, which is also just called pulse, and then times stroke volume, which is the amount of blood that the heart pumps in 1 minute. On average, for a person at rest, that does end up equaling about 5 liters of blood per minute, which does happen to be your entire volume of blood every minute. So when you're trying to maintain homeostasis, generally speaking, if your heart rate goes up, your stroke volume is going to go down so that you can maintain cardiac output. So you can play with either one of these two things to try to keep cardiac output equal. However, sometimes your body wants to raise cardiac output, like let's say that you're trying to exercise. Well, in that case, you want to deliver more oxygen and more nutrients to cells because they're being more metabolically active. So you want to up cardiac output. So what's going to happen is your heart rate is going to go up and your heartbeat is also going to become more forceful. That's going to increase your stroke volume as well. And so both of those things are going to have a synergistic effect on cardiac output. When it's time for you to come back down after your exercise and you want your cardiac output to come back down as well, you're going to lower both of those two things back down to bring your cardiac output back down. So you can tweak all of these numbers to try to get your cardiac output wherever you want to be. But if you're just trying to maintain, those two numbers are going to have inverse reactions. So if heart rate goes up, stroke volume will go down and vice versa when you're trying to maintain. So stroke volume I defined just a second ago. What basically contributes to this is how forcefully the cardiac muscle itself is contracting. So the stronger the contraction is, the more blood will be ejected with each contraction. So the more blood gets pumped with each beat. So that's going to increase your cardiac output. Again, this is sort of, you know this sort of thing already. When you're exercising, you know your pulse gets stronger. That's because your stroke volume's getting stronger. Your heart's actually beating harder when you're exercising. Cardiac reserve. This is another thing that I'm hoping you guys know. You know there is a difference between what your heart can do at rest and what your heart can do when you're exercising. There's something that's called target heart rate. It is where your heart should be beating, the number it should, your heart rate when you're exercising. It's different depending on the age of the person, the sex of the person, the health of the heart, all that sort of stuff. But that declines as you get older, your target heart rate, and that's because your cardiac reserve declines as you get older. One of the things that you can do to try to maintain that cardiac reserve is making sure that you're doing some type of cardio workout. And that's, as basic as walking. If you want to do something a little bit more intense, you can do jogging, running. There's ellipticals, there's stair machines, there's rowing, which is great for a full body workout as well. There's all kinds of bike machines, but anything that gets both your heart and your lungs working, that's going to help your cardiac reserve. Strength training is great for a bunch of things, not so much for cardiac reserve. It's great for bone strength, for muscle strength, but if you want to make your heart stronger, you got to do a cardio workout. There are two factors that contribute to your stroke volume, in addition to just how strong can the muscle itself contract, and that is how much blood is actually in the heart. So these two things we alluded to in the previous video. Once again, this is one of those times where your book gets to be a little bit alphabet soupy. So EDV is end diastolic volume. ESV is end systolic volume. What they are trying to abbreviate here is essentially what is the volume of blood at the end of diastole. So you have to remember diastole is relaxation. So at the end of the heart's relaxation, how much blood is in the chamber. So EDV is going to be the amount of blood in the chamber just before we contract. Then the heart contracts, and then we have ESV, which is the amount of blood left in the chamber at the end of systole. Because contrary to popular belief, the heart does not pump every single drop of blood that was present in the heart. There's a little bit of blood that remains in the heart. So that little bit of blood that remains is your end systolic volume. EDV minus ESV gets you your stroke volume. Okay. I really already gave this to you earlier and sort of talked you through that stuff, and so you should be okay with that formula for cardiac output. Okay, one of the other things that plays a role in your cardiac output is venous return. It is the amount of blood that the heart is having returned to it through the venous system. So how much blood is coming back through the superior vena cava, the inferior vena cava, and a little bit through that coronary sinus that we talked about earlier. This is a factor of blood pressure. This is a factor of how much are you moving. There's a lot of different little things that come into play in terms of venous return. But if blood's not coming back, of course, your heart doesn't have anything to pump. So if your venous return is low, that means your EDV is going to be low, which means stroke volume is going to be low. And remember, stroke volume plays a role in cardiac output, which means cardiac output is going to be low. And then you end up getting this cycle that keeps making everything lower over and over and over again. And eventually that's going to cause shock, which is going to end up killing a person. And so you have to try to do something to get venous return back up so that you can get EDV back up, so that you can get stroke volume back up, so that you can get cardiac output back up. Vagal tone means that the heart rate is where the heart rate is supposed to be. And again, for a person at rest, it is between 60 to 100 beats per minute. It means the SA node is doing what it's supposed to. The brain is slowing us down. Again, left to its own devices, the SA node would tend to set a resting heart rate that's closer to 100 beats per minute. So the parasympathetic system, like the slide says, via the vagus nerve tends to slow it down to closer to that 70-ish on average, but it does vary person to person. Lots of hormones are going to have an effect on your heart rate. We talked about epinephrine way back in chapter 16. That's going to increase heart rate. Remember, that's the same thing as adrenaline. Thyroid hormone is also going to increase heart rate, and it is going to increase stroke volume. So both of those are two things that are going to increase your cardiac output. Excuse me. All right, so your EMIAs is what I'm calling all of these collectively. So anytime you see EMIA, it's a blood value of something. So hypocalcemia, remember what hypo and hyper always mean. Hypo deficient, hyper excessive. Calc means calcium. Kale in this case, or kali, is potassium. So hypocalcemia is deficiency of calcium in the blood. That's going to depress heart rate, make the heart slower. Hypercalcemia is going to make the heart a little bit twitchier and increase your heart rate. Both of those are, of course, very bad things. So remember, everything I've been stressing is calcium's more important than just strong bones. Too much potassium, hyperkalemia, will full on kill you. The story that I always give there is one of the drugs that Texas used to use, might still use, they've started hiding what drugs they use for people on death row. But one of the things that we used to give was potassium, and that's because potassium stops the heart. It prevents the sodium and potassium channels from working like they are supposed to, and as a result, you can't depolarize, repolarize, and so the heart just full on stops. Hypokalemia does something fairly similar. The heart is going to have very weak contractions, so it's still going to mess around with your heart rate, but the high potassium will full on stop the heart. Tachycardia means your heart's going too fast at rest. Too fast is defined as over 100 beats per minute at rest. I do again want to stress that at rest. If you're exercising, it is perfectly normal to have a pulse that's like 120 and if you're young enough, 180, 190 or something. But if you're at rest and it's that high, that's not okay. That can set the stage for fibrillation, and that's something we want to be on the lookout for. Bradycardia is the exact opposite. It is too low, so that is less than 60 beats per minute while you are at rest. That may not be a problem. It might mean that your heart is just really strong and it's keeping cardiac output fine. But it might mean that your heart is trying to conserve energy and it's not keeping blood pressure where it's supposed to be. So it might be a problem, it might not. Pretty much kind of already hit on these two things and how they were related just a little bit ago. But where we're going with this here in just a second, and your book sort of dips its toe in and then backs off and then it comes back to it, is the disease known as congestive heart failure. Congestive heart failure means your heart is not keeping up with the blood that is trying to come back to it. It is usually the result of heart damage on one side versus the other. So let's say a person's had a heart attack. When a person has a heart attack, remember it's usually the result of damage like a clot that has gotten stuck in a coronary artery. So the damage is localized to a specific part of the heart. So like part of the left ventricle dies or part of the right ventricle dies. It's not like the whole heart dies as one. So when a person has a heart attack, that means the right side of the heart might start to fail or the left side of the heart might start to fail. Depending on which side is failing, different symptoms will end up developing because one side is not keeping up with the other side. And so we have a congestion of fluids building up prior to the side that is failing. Here in this set of pictures, we have a person who has what's known as pulmonary congestion. Now here in this case, congestion is not you have a snotty nose. It's you are congested with fluid because the heart is failing. You can see the cloudiness in the lungs in these images here, especially in the forward image on this one for the January of 2004 image. So what happens here in this case is the left side of the heart is failing. So the right side is still pumping the blood out to the lungs, but the left side's not able to keep up, and so blood starts to pool backwards into the lungs because the left side's not ejecting it as fast as the right side is pumping it, and so that fluid builds up in the lungs itself. Our treatment for this will be diuretics. We'll talk about that again in a minute, and that's exactly what they did. They gave this person diuretics, and notice we've gotten rid of most of the fluid. The lungs look a lot clearer in this image than they did before. Diuretics don't fix the heart. They just help you get rid of that fluid. Now, coronary atherosclerosis is another reason why part of the heart may end up failing. Atherosclerosis is a buildup of this plaque that you can see in the walls of the arteries. Now, since we're saying coronary, that means this is happening in the coronary arteries. This decreases the size of the lumen, which increases the blood pressure in the lumen of the coronary arteries, and that has its own, so we got this hypertension that starts to develop inside of there. This can also start to cause rough little deposits in the endothelium that makes platelet plugs more likely to develop, and that makes clots more likely to develop, and so that can make the full-on heart attack, which is where we get the second part to this, more likely to happen. So this is sort of one of our precursors to heart attacks, and heart attacks are the precursor to congestive heart failure. Hypertension is high blood pressure. Used to be you were considered hypertensive if your systolic or upper number in the blood pressure reading was over 140. They did probably, I don't know, like 3 or 4 years ago. Time is weird for me at this point, so I don't remember how long ago it was at this point. So now it's not 130 or 140, it is 130. So if your top number in your blood pressure reading at rest is over 130, you are considered to be hypertensive. That puts more strain on the heart, makes heart attacks more likely to happen, makes valve failure more likely to happen, makes aneurysms more likely to develop. It sets the stage for a lot of problems. They consider hypertension to be a silent killer because you can have it and show no symptoms and think you're just fine, but there's all these behind the stage problems that are developing, and eventually those problems can end up killing you. And so hypertension, you might not realize it's a problem, but it's a problem that can kill you. Now, let's kind of go back to one of the ways that hypertension can kill you. Whenever you have hypertension, that means the pressure in the blood vessels is already high. So when the ventricles try to pump the blood into the vessels, they're trying to pump blood into vessels that already have high pressure. And the thing about blood is blood always wants to go from high pressure to low pressure. And so if we're trying to pump blood into a high pressure area, that's very difficult to do. So in order for the heart to pump blood into a high pressure area, the muscle itself has to get bigger and stronger. So it's sort of like at first, your heart is getting a workout. And that sounds like it's a wonderful thing until you remember the heart is in an enclosed space. Remember that it's in the pericardial sac. It cannot just keep getting bigger and bigger because it's in that enclosed space. Eventually, it will start to build up pressure within that enclosed space. That pressure will start to damage the cells of the heart itself, and then the ventricles will start to get flabby and weak because of the pressure. And then now you have dilated cardiomyopathy, and your heart is completely incapable of maintaining any pressure at all. Dilated cardiomyopathy, as many things in the heart, will flat out kill you. There is no treatment aside from a heart transplant. And heart transplants are one of those things that, again, people think it's, yay, I got my heart transplant, I get to skip off into the sunset. They don't last forever. Heart transplants have a shelf life, and you don't tend to get a bunch of them. You get one, and that's it, because a lot of people die on that transplant list. And so you want to make sure if you have hypertension, you do what you can to lower it, because you're not going to get a third chance or a fourth chance when it comes to not maintaining your blood pressure. Okay, so let's draw out congestive heart failure is what I say next. So with my wonderful mouse, I don't know why I'm using my mouse. I think it's because I've realized I'm crap with the pen, but I still think I'm better with the pen for some reason. Okay, so thicker wall, just so that you guys can see which side's the left and which side's the right. This is our left side. This is our right side. I'm going to make this a super janky heart. Okay, so let's make our volumes nice and simple. And let's say that on the right side, we have 100 milliliters of blood that is coming back to us from circulation. That's venous return. If the right side is doing its job, that means it is supposed to pump out 100 milliliters of blood to the lungs. That same 100 milliliters of blood is supposed to come back to the left side, and then the left side, it's supposed to pump out 100 mils. Despite the fact that the left side has that thicker muscle, the volumes being pumped are the same all the way around. The pressures aren't, but the volumes are. Now, I'm going to change colors to start to indicate problems. Let's say that the person's had a heart attack and we've damaged this part of the wall. Left side is still just fine, so it's still pumping out 100 mils. 100 mils is still coming back to us on this side, but because of this damage in the wall right here, the right side can no longer pump out 100 mils of blood. It's not strong enough to do that. So now, I'm just going to do this to keep our math simple. We're going to say that it's only capable of pumping out 50 mils of blood. That means 50 mils of blood are going to be backing up prior to the right chamber. And you got to think about, where is the blood before it comes to the right ventricle? Well, it's coming from the superior and the inferior vena cava, which means it's coming from everywhere in the body systems. So this is what's going to lead to peripheral, I hate that my monitor shakes, peripheral edema or peripheral congestion, because that fluid, again, has to go somewhere, and it's going to back up before where the damage has occurred. So the person's going to end up with swelling in the feet, the ankles. I'll show you some pictures of how we would deal with that a little bit later on. Okay, now I'm going to switch colors again. If my clicker will click with me. Okay, now let's say that instead of having a heart attack on the right side, person's had a heart attack on the left side. So right side is still pumping 100 mils. We've got 100 mils trying to come into the left side, but now because of the damage on the left side, it is not pumping the blood like it's supposed to. So now we're going to be backing blood up into the pulmonary veins that were draining blood from the lungs, which means now we have pulmonary congestion, which is that picture that I showed you a little bit ago, and I'm going to show you again here in just a second. Oh my goodness, that looks like a whole different word. Congestion. There we go. Now I've said it a little bit better. So what tends to mess people up here is they want damage to the right side to lead to pulmonary congestion, but it's the opposite. Damage to the right side leads to peripheral congestion. Damage to the left side is what leads to pulmonary congestion. So it's backwards from what you think, because we're backing up to the previous side, not to the future side. It's a backup, not a forward up making up words now. So here's again what the pulmonary congestion looks like when the left side of the heart is going to be problematic. That fluid starts to build up in the lungs itself. If you have never seen a person suffering from pulmonary congestion, it is not a pleasant sight at all. They are literally drowning in their own fluids. They will very often cough up like this frothy, just unpleasant fluid from their lungs. They are very distressed when that is happening because, again, they are drowning and they are miserable when that is happening to them. And again, the only thing that we can really do is do things to try to get rid of the fluid. And so we'll give them diuretics that's going to help them pee out the excess fluid. And again, does not fix the underlying problem, which is the heart. The only thing that would fix the underlying problem is a heart transplant. And since a lot of the people that have congestive heart failure are older, they tend to not get heart transplants. Those tend to go to younger people that have a little bit more life ahead of them. And so very often we are just trying to make the people with congestive heart failure more comfortable. And so it's just the diuretics to give them a better quality of life until it's too late. That's morbid, but unfortunately that's the way it goes in a lot of cases. Peripheral congestion, on the other hand, you get swelling in the extremities. This over here is what's known as pitting edema. It's called that because if you were to take, in this case, your thumb and press it into the person, you leave a thumbprint in them. Their swelling is so severe. Try it with yourself. Just stick your thumb onto your foot and you'll notice your skin rebounds really fast. But in these people, they have so much fluid built up in their connective tissue that it has no place to go. There's no rebound left to the tissue. One of the other dead giveaways that there is peripheral congestion. So this is a distended jugular vein. The jugular veins empty into brachiocephalic veins, which empty directly into the superior vena cava. Gravity drains those directly. So if a person is sitting up, you will almost never see a distended jugular vein because the blood is just draining directly into the right atrium. So if you see a distended jugular vein in a person who is sitting upright, it means the right side of that heart is not keeping up with venous return and it's backing up, and it means the right side of their heart is failing. This is a little bit more severe. You cannot do decongestive therapy on a jugular vein. That would suffocate a person. But you can do decongestive therapy on this side with the compression boots. These are the compression boots. And again, if you work in a hospital or nursing home, you're going to get really good at putting those boots on, taking them off, turning the little, it's almost like a nebulizer. If you've ever done a nebulizer, it's just a little air compressor. You turn it on, it blows the boots on. Up the boots, then squeeze the legs to try to squeeze some of that fluid back into circulation. Again, does not fix the underlying problem, but it's trying to get that fluid moving again so that the person's skin doesn't start to seep. If you see a person whose skin is dewy, it's because the fluid is starting to literally leak out of the skin, and that is problematic, of course. The diuretics I mentioned, remember diuretics are the opposite of antidiuretic that we talked about back in chapter 16. They make you pee out excess fluid. So a person put on diuretics is going to need to pee a lot. If they're on a catheter, you're going to need to empty that bag a lot more than you would have before you put them on the diuretic. If they're not very ambulatory, but they are not catheterized, you're going to have to be taking them on more bathroom breaks or changing whatever diaper or pad or whatever they are on more frequently. Again, this does just help get rid of the fluid to make the person more comfortable. All right. Fetal stuff as related to the heart. So there were 2 different shunts present in the fetal heart that helped blood skip the lungs since the lungs aren't working in a fetus. We talked about the hole in the interatrial septum that is called the foramen ovale. That closes up and then becomes that weak spot called the fossa ovalis. So that comes back here. There is also a little shunt, let me come over here to it, between the pulmonary trunk and the aorta. It's called the ductus arteriosus. So remember that the pulmonary trunk splits into the pulmonary arteries that are going to take the blood to the lungs. Well, we don't, again, really need to take the blood to the lungs. And so this little teeny tiny blood vessel essentially allows the blood to go straight into the aorta from the pulmonary trunk so that we can just skip the lungs altogether. So it's just another way for the blood to skip the lungs in the fetus. Sometimes if a child is born prematurely, those holes will not close up, that ductus arteriosus will not close up. Sometimes babies are on a slightly delayed developmental pattern, and those things won't seal up for several months after the baby is born, and that can be okay. Sometimes those things don't seal up on their own ever, and the child is going to need surgery to fix the problem. So a septal defect means the hole did not close up like it was supposed to, or there were extra holes. Like there have been babies who are born with interventricular holes between the right and the left ventricle. That is also problematic, and that's going to require surgery to fix. It's a fairly routine surgery. They do that all the time, but it's still very, how do I want to describe that? It's still very troubling for the parents because their newborn is going to have open heart surgery. So even though it is a very common procedure, it's still very disconcerting for the parents. PDA is patent ductus arteriosus, and I think this is the first time we're seeing the word patent in A&P. Patent means open, so patent ductus arteriosus means the ductus arteriosus doesn't close up like it's supposed to and it stays open. So the shunt between the pulmonary trunk and the aorta doesn't close up, and so the blood is still skipping the lungs after the child has been born. That will also require a surgical fix. If it is not fixed, what will happen, the child will very often look perfectly normal most of the time, but when they start to cry or poop or do anything that makes their face scrunch up really good, they will often develop cyanosis, especially fingers, toes, and lips, which is what you're seeing off down here. That tends to mean that there's a problem with the heart. And if it's happening a lot, that means that they need to go in and be looked at because we need to fix whatever the problem is that's causing that cyanosis. All right, so that was the fetal side. Now the aging side. As we get older, remember, if there's any heart damage, you can't replace heart muscle with heart muscle. Instead, we replace heart muscle with fibrous scar tissue. So one of the things that just happens to all hearts as we get older is they become more fibrotic, which it says that down here. That means all hearts become less efficient as they get older. Exercise can help reduce that a little bit, but that only helps a little bit. Everybody, as they get older, your heart becomes just less efficient. Atherosclerosis, that buildup of plaque we talked about, that happens in everybody, but diet and exercise can make it happen less. And so make sure you're eating a proper diet and you're exercising. Decline in cardiac reserve, again, diet and exercise can make it decline less, but everybody's cardiac reserve is going to decline as they get older. And then sclerosis is just another one of those things that happens as you get older that is partly because of the fibrosis, and then it's also just because a lot of our tissue tends to build up a little bit of extra calcium as we get older, and that tends to make the tissues get a little bit harder over time. So let's see. One of the other things that I just kind of like to leave this one with is it goes back to something that I said in one of the earlier videos. When a person is flatlining, you do not grab the paddles and shock them. When a person is flatlining, you do chest compressions. Once you start chest compressions, you do not stop them until the person has a rhythm or until there is a doctor there to declare that person dead. So let's say that you live way out in West Texas and you are an hour away from the hospital. It is going to be your job to sit there and give a person chest compressions for that whole hour's trip in the ambulance to that hospital. So they've actually developed these devices. They're called Lucas. They do chest compressions for you. And I just like to show this video so you can see how brutal a chest compression really is. They are not namby-pamby. And honestly, you are more than likely going to break some ribs if you are doing CPR. So here's what a Luca device looks like. And here's what chest compression should look like. That is a real patient who really needed Luca, and that is really what chest compression should look like. It is fairly brutal. If it does not look like that when the nurse, doctor, medic, whoever is doing the chest compressions, then they are not doing it right. So you've got to press hard enough that the whole point of a chest compression is that you are squeezing the heart to get the blood out into circulation. And so if you're not squeezing hard enough, you're not actually moving any of the blood. So this device helps take over those chest compressions, because I don't know if you've done them, they're exhausting. If you have done them for 5 minutes, that's your cardio for the day. It's that tiring. So hopefully that helps you understand a little bit more about the heart and why how you do CPR, why you don't use paddles, and then just some basic heart stuff. As always, if you have any questions about any of the notes or heart things, don't hesitate.